Thanks, Alex, for the nice introduction and, of course, invitation to be the very first speaker of these discrete optimization talks. I'm very excited. And I hope this series of events continue even after the pandemic goes away. So regarding that, I'm going to talk about resource allocation, ventilator allocation and sharing to combat COVID-19. This is truly a joint work with my postdoc advisor, Professor Mehdotra, Masood, Hengshao, and Carolina, all at Northwestern University. And I'm just representing the whole group in this talk today. I'm going to start motivating what we have done, introduce the problem, what are the challenges. I'm going to present a mathematical model, followed up by some computations and insight that we can get from the optimization model. Before I move forward, I'd like to say, although I'm speaking at discrete optimization talks and my model has some discrete variables in it, but it might be very different from the other talks that you would see in this series. I'm not going to do any fancy stuff about discrete variables in my model. This is truly a practical applied project that we did over the past months. All right, I don't need to see what's going on. We have all been facing a real issue in the past month or two in the state of Illinois, where I am. We have been in the lockdown for over 6 weeks, I guess. And it has been a similar situation over US and also all other countries around the globe. I just want to give you some numbers. As of today, according to the Johns Hopkins University that has provided a number of statistics about this pandemic, around 2.5 million cases has been confirmed globally, out of which around 700,000 people have died, out of which around 1/3 of the cases has been in US, with around 25% of the deaths has happened in the US. So we all know that most cases in this COVID-19 situation has been very mild. Around 80% of the cases are mild. And there are some severe cases that can result into respiratory failure where the person's lungs are not capable of pumping oxygen into the blood for the functions of the organs. So in this situation, we have to provide the patient with mechanical ventilation in an intensive care unit in order to help them to survive and be able to combat and fight with COVID-19, which are around 5% of the cases of COVID-19 patients has to be on mechanical ventilators. So the governments and the states and countries' capability to bring down the death toll really depends on how much mechanical ventilation they have in their supply. However, this resource is very limited. The states, there has been news as of late March that the states are competing with each other in order to obtain ventilators from manufacturers. For the states like Michigan, Louisiana, or New York that were hit early and very hard, they were all have been forced to compete with each other to obtain ventilators. For example, in the state of New York, according to Governor Cuomo, whom you might have heard his name frequently in the news, as of March 31st, the state had ordered around 17,000 ventilators at the cost of $25,000 each in order to provide sufficient supply for the patients in the state of New York. These, if I want to give you an idea, these ventilators, which are discussed, are about the size of a dishwasher. And they're very, as I said, very crucial for the patients to have access to in order to survive. If a patient is put on ventilator, they need to be on ventilators for around 2 to 4 weeks in order to survive. So at the same time, the government, the federal government has tried to coordinate this issue according to the US presidential briefing from the coronavirus task force on March 31st. It was mentioned that around 8,100 ventilators were allocated to different US states by the US Department of Homeland Security, Federal Emergency Management Agency, FEMA, which you will hear about frequently during this talk. Different states got part of this initial inventory of ventilators. For example, Out of that, 400 ventilators went to Michigan, 300 went to New Jersey, 50 to Connecticut, and 450 to the state of Illinois, in addition to the 400 ventilators that went to New York. As time goes on and more data became available about the possible situation that can happen about the number of infected people from the COVID-19, for example, one of these early projection and forecast on the numbers came from the Institute for Health Metrics and Evaluation, IHME. Again, you might have heard of this institute in the US presidential briefing. They showed and they estimated that different states will hit their peak demand at different time periods throughout the months of April and May. In the figure below, you will see, for example, as of today, based on the data that was published on April 17, the state of New York hit its peak on April 15, around this time with this number. This is the demand, the curve of the need for the ventilators. And also the state of Michigan hit its peak on April 18 around this time with this number of ventilators that are needed. So this problem, in what we have realized, is that is implying a really unique feature, that because the states are showing and hitting their peak at different time periods, there is a possibility for states to use their available inventory of ventilators when they need it, and after their peak fades away, they can share that inventory of ventilators with other states, which was something that was observed with us, other researchers, and also you would see some articles in the news about such a possibility where in this article in USA Today on April 6th, it was mentioned that we can get equipment and resources from less stressed hospitals and states and share them with overwhelmed hospitals and states in order to reduce the shortfall of ventilators and to save lives. So these observations were also were seen in practice, where as of April 4, the state of New York got 1,100 ventilators from the state of Oregon and also China. There was also some news that New York got some ventilators from California, which hadn't hit its peak yet at that time. And now that the state of New York has passed its peak on April 15, according to IHME, they have started to giving away their ventilators to other states. That they have announced that they're going to give away 400 ventilators to the state of Massachusetts based on this news on April 19. And remember, the state of Massachusetts, according to IHME, hit their peak on April 18. So this is a possibility that we saw, and we got together on on March 26 with the goal of developing a multi-period planning model for a centralized allocation and possible reallocation of ventilators over a planning period that we had considered in order to reduce shortage and save lives. What we proposed can be used as a planning framework for states and also the federal agency that coordinate this allocation and reallocation of ventilators, FEMA, under different demand scenarios. And as part of this effort, we developed an interactive online tool, which was published and made online on April 6, which can be used as a planning framework. It might not be bad to take a look at this website before we move forward, to give you a glimpse of what we have done before getting into more details of the mathematical model. You can see here that the model that we have provided, the website, this platform, gets different parameters that I'm going to talk about in the mathematical optimization part. We'll give different inputs on the demand scenarios, different parameters that the states can control, the lead times of delivering ventilators to the states. And you can see there's a panel that, as I move this panel, you will see how the shortage over states is changing. Some states are getting more severe, the situation gets more severe. Some states are fading away, they're becoming completely fine. They don't need to have additional access to resources. And you can see all this data that is changing here is showing the amount of the ventilator that the states need, the amount of ventilator that they have in their inventory, and how much shortage they have. All these numbers in this table is coming from the optimization model that I'm going to talk about in a few minutes. You can go to that website and see how your state is doing, and hopefully that provides some useful insight for you. All right, so I'm going to talk about now about the mathematical formulation. Hopefully so far I have motivated that this problem have some opportunities for operation research community to come into. Before I move forward, let's say what we have, what kind of resources we have to meet the demand for COVID-19 patients who need ventilator. So states have some initial inventory that part of it could go to the COVID patients. FEMA, the central agency, has some initial inventory that could also allocate to states. According to the March 27th news, U.S. presidential briefing, President Trump invoked U.S. Defense Production Act, where the companies were forced and compelled to produce ventilators in order to be added to the national stockpiles. Companies like Ford, GM, and General Motors were and Tesla were asked to produce. Here's a question. Okay, to produce additional ventilators. And these are the initial inventory that we have. And what we need to do is to decide on how to allocate these ventilators to states. And if states don't need the ventilators, they should send back to FEMA in order to be shared with other states. So essentially what we have to do at each time period for both FEMA and states is that they have to decide whether to reserve their inventory in anticipation of the future stochastic demand or to share it with other entities. So the way that we can model this problem, so I lost my, okay. The way that we can model this problem is through a sequential decision-making problem under demand uncertainty for ventilators, where at each time period, the states and FEMA has their initial inventory level that they can use. The stochastic demand is realized. States and FEMA has to make decision on allocation and reallocation decisions of ventilators, which is captured by this variable U, if you like, which is a function of the initial inventory and also demand. And as we make this decision, the state of the system, the current inventory level of the system is updated, which is again a function of decisions, initial inventory and demand. And all these decisions are imposing a cost to the system, which is a function of all these three parameters. So this is an ideal model that we wanted to use. It's a sequential decision-making problem. You can think of that to be modeled as a multi-stage stochastic program, or if you're from a control community, you can think of a stochastic optimal control that can be used. This is an ideal model. As I said, we did not follow this path, but if you're interested, you can learn more about how to obtain optimal policies for such a framework from Warren Powell's website and contributions to the field. So instead, we decided to model this problem with a two-stage stochastic program with Recourse as an approximation to that multi-stage model. What we do is that FEMA, or the federal agency, is going to make allocation decisions in the first stage, here and now, before knowing what's going to happen in the future. And once the stochastic demand are realized, recourse decisions are made in order to reallocate ventilators and to share ventilators with other states. And our goal is to minimize the expected shortage. Of course, because I'm doing an approximation, one should ask, what's the value of the multi-stage program in this setting? And you can theoretically investigate that. And you can also look for works in the literature and work of Shabir and his colleagues. All right, before I move forward, I'd like to ask if there's any question. I'll be happy to ask. Otherwise, I'll move forward to the details of the model. All right, it seems there's no questions. Let me move forward. The model is fairly simple. I usually won't present the mathematical formulation in a talk, but because this is a problem of national interest and also the model is simple, I'd like to present it. As I mentioned, there are states that are some of the entities that are acting in the system. We are showing that with this set N. There's some planning periods that we are showing with this capital T set. The demand for ventilators at the given time period at the given state is stochastic. It's captured with this D parameter. And also, as I mentioned, we have some initial inventory and productions that can be used to satisfy demand. They're all captured through the Y parameter, the initial inventory at the state level, I, the initial inventory at the FEMA level, and also the production that is added to the system through this DPA act. We also have some other deterministic parameters, which I believe are the most important parameters that we have considered in our model, which basically are about how the sharing of ventilators happen between the states. If you remember, we have some historical inventory at each state, and part of that inventory must be used for non-COVID patients that capture this gamma parameter. The states have the control over their initial inventory on how much of this initial inventory they would like to share with the other states. That fraction is captured with this tau parameter. And also the states are risk averse in order to share their ventilators with other states. They would like to consider a safety stock for their inventory. And if the level of inventory is higher than a threshold, they would be willing to share that with other states. Otherwise, they would not share that with other states. So the way that we have modeled this problem, as you can see, is by parameterizing this, this model using these three parameters that are going to have some impact on the output of the optimization model. So I haven't introduced yet the decision variables. And as I said, we are considered a two-stage stochastic program. Here and now, we take the first stage decisions, which is on how much a ventilator FEMA should allocate to different states that's captured with this decision variable X. As the stochastic demand is realized, the state has to decide how much of their inventory should allocate to FEMA in order to be shared with other states that's captured through the Z variable. And also we have to update the inventory at this state level, Y variable, and also the inventory at the state at the FEMA level, this S variable. So as you might guess, I'm going to present a simple inventory problem model through a two-stage stochastic program. In the first stage, we are going to make decision on the X variables here and now. The FEMA is going to make decisions for all periods that would incur a cost to the system. You can think of that as a shipping cost that would happen. And we also need to consider the cost to go function, which is captured through this F function. And as I said, we are going to minimize the expected cost. So now let's move on to the second stage cost. The second stage is a function of the stochastic demand and the decision that we have made in the first stage. We want to minimize the total shortage, which is captured through this positive term here. Demand minus inventory plus is the shortage. I would have the standard flow balance equations for the inventory. The first equation is the flow balance for the state. The second one is for the federal agency, FEMA. I would impose some constraints on how much ventilator from FEMA can go to other states. This is captured through the shared constraints. I have some initial constraints that are capturing the initial inventory plus some non-negativity of the variables. And I still need to explain what does this constraint do. And I'm going to talk about that in particular in the next slide. So basically this variable, if you remember, Z is the number of ventilators that are going to be shared with other states by giving away to FEMA. So what basically this constraint is saying that the states are going to share their inventory if the amount of inventory at the state level is higher than the safety stock, which is captured by this gamma, by this rho parameter. So the state inventory can be divided in two sections. The initial inventory, which is this Y0 inventory that we have from historical inventory, and also part of the inventory that we have got from FEMA, which is captured through this difference term. So states are imposing their control over how much of their initial inventory has to be shared with other states, as you remember, through this tau parameter. And this whole term here is the inventory at the state level that can be shared. So the states are willing to share their inventory if the first term here, this total term here, is larger than the safety stock. So all right, so as you can see, this constraint is non-convex. So I have to take care of making that constraint to be linear, which is done through the standard big M formulation. I have introduced some binary variables in order to linearize that constraint. You could have also observed that the objective function is also nonlinear, but because we are doing minimization, that's already convex. So I just need to capture the nonlinearity objective function through this simple forms. And so I already had some integer variables in the model. I have introduced some binary variables now into the model. So basically what we have proposed is a two-stage stochastic program with integer variables as an approximate to that multi-stage problem that was nonlinear. We have also considered other factors into the model. You might think of considering lead times into the model, whether that you have sent to some entity will be available sometimes later. That's captured through this parameter L. It will make some changes to the earlier constraint that I explained. All right, so one basically could consider that the number of stochastic demand scenarios are finite and consider a deterministic equivalent formulation for the problem and solve it through commercial solvers. But before talking about how the solution came out, I'm going to talk about some of the input parameters that we have in the model. We consider a planning period of 70 days from March 23rd to end of May. For the demand information, we use IHME's projected confidence interval, and we use the database that was published on April 2nd. And according to that confidence intervals, we generated different demand scenarios in order to capture different mitigation strategies like a stay-at-home order, a stay in place, and business closures in order to capture how the number of infected people who would need ventilators would evolve over time. Let me not get into the details of this, but we basically generated 6 different scenarios, 6 different cases to generate demand scenarios. As we go from top to down, the severity of the cases becomes more problematic. In this final case, we will have considered only one demand scenario, which is at the upper limit of the confidence interval. In other cases, we have, for example, considered that 100% of the demand are concentrated on the top quartile of the confidence interval, and so on and so forth. To give you an idea, this is how the trajectory of demand for ventilators is over time for the state of New York. As you can see, in this case, we have some demands that are spread over the vertical line. As I move and go to the other cases, the demands becomes more and more concentrated on the top part of the quartile. And you can see here, there are more demands in this portion, more demands on this portion. And finally, in the case, the most severe case, I have only one demand scenarios. We can talk more about how the demand scenario generation happened, but let's move forward with other parameters. If you remember, we had other parameters in the model, including the initial inventory at the FEMA levels. We got that from US presidential briefing that FEMA, as of March 23rd, had 20,000 ventilators in hand. We obtained the initial inventory of ventilators from the American Hospital Association's survey that had been done over the year of 2010. We obtained the information about the production from also the US presidential briefings at the current daily ventilator production for ventilators before the DPA was invoked was around 80 ventilators per day. And after that, we would expect that it would get to 10,000 ventilators per month, which would bring it down to 320 per day, starting from April 15. We consider different parameters and values for these three parameters that are very important for the model: gamma, rho, and tau parameter. And also we considered different possibilities for lead times. So overall, what we had considered is a number of 81 different settings per each demand case. We had 6 cases for how the trajectory of the demand for ventilators could evolve, and we have a total of 486 problems that needed to be solved. As I mentioned, we formed a deterministic equivalent model of the problem, assuming that we have a finite number of scenarios per case. We solved that with Group B Python and solved them on 2 machines in parallel. In order to solve the model, we decided to relax the integrality constraints on decision variables and only keep the binary variables that were used to linearize the resource sharing constraints. And we observed within a time limit of 2 to 3 hours, we could not even obtain an integer solution to these problems, yet we were not able to solve them to optimality for many of the instances. So we finally decided to solve an expected value problem and obtain an integer solution. So we took that as a heuristic to obtain an integer solution that would give an upper bound on the optimal value. So I'm not going to provide much details about the numbers that we obtained, but I just want to give you some big picture of what we have realized. We realized sharing inventory with other states has a crucial role in reducing the number of shortage. We observed, for example, if states are going to use only 40% of their initial ventilators inventory for COVID patients, the initial inventory of 20,000 ventilators that FEMA has is nearly sufficient to meet demands in mild cases. But if states are going to share more of their inventory with other states, we can see that the number of shortage would go up around 13,000 ventilators beyond what FEMA has already in hand. The situation, of course, gets worse if the demand scenarios become more and more severe and the states are not going to share their excess inventory with other states. So I have some numbers here. Again, this is one of the most dramatic cases that we had considered. The states are not willing to share their inventory and they're using a very high parameter for their safety stock. In a worse state and a worse situation, we might have around 30,000 ventilators shortage in the whole US. So let me wrap up. What we proposed was a model that can be used as a planning framework for states and the federal agency under different demand scenarios that could capture different mitigation strategies with respect to COVID-19. What we have found out is that in a resource constrained environment where demand for different entities peak at different time points, it is a possibility to share resources and obtain and improve efficiency in resource utilization. We observed that sharing inventory with other states could make the resource utilization more efficient. If the states are not willing to share their resources, the situation might get worse. Let me tell you what we are. So these are what we had done so far. And let me tell you what we are planning to do as time goes on. We are at this time are advocating for our model and trying to operationalize it at the national level in partnership with other institutions. We are considering extensions to the model and some other consideration that can be taken into account, including considering different type of ventilators, considering different objective functions, and also taking into account logistical issues. Nevertheless, we believe what we have developed has the capability to be transformed to other countries and also at the international level, and even at more granular level where we can consider different states, hospitals, and healthcare facilities. It can also be used toward other shareable resources, and if any other pandemics happen in the future, we believe that this model and the unique feature that this model and this pandemic revealed can be used toward other situations as well. With that, I'm going to end my talk. You can get access to the latest version of the article, which came as part of our effort using this QR. The paper has been accepted for publication and is hopefully will be available in press very soon. Thank you so much. I'll be happy to take any questions if you have any.
Thank you, Hamed, and really nice talk. And we're really happy that this was the first one because it shows how relevant discrete optimization is to the current situation. So thank you very much. There will be a few questions, I think, coming up either in the chat or people raising their hands. So if you have a question, please do raise your hand and I will unmute you. There was one hand raised that I saw. Let me unmute here. It is. Go ahead, Ali.
Yes, hi, hello everyone. Thanks, Hamid, for a very good and timely talk. So one quick question I have is, did you consider comparing your results with those of, I don't know if you know that website that a lot of officials are using, the COVID-19.healthdata.org. I think they also give estimates of needing ventilators and so on. I think it would be interesting to see how close or far your results are from what they indicate there.
Sure.
That's one. The other question is regarding supply. I think supply seems to really be random nowadays because multiple sources are starting to ramp up and some car manufacturers are going back and forth in, supplying things. So I also wonder if you consider that to be random. I think your model can easily change it or update it to consider that, but also we probably might run into issues of having it get solved quickly, and I'm also not sure how much that would affect the solution. So yeah, I would appreciate your thoughts on that as well.
Sure, I can try to quickly answer your question. Yes, we actually used IHME data, this COVID-19 health data that you mentioned. That's what we used as forecast for the demand for ventilators. We didn't develop our own model to forecast demand for ventilators. We used their data and we used their confidence interval that they had forecasted for the number of ventilators that are needed. As part of the input to the model, what we did was to bring that forecasted intervals, confidence interval, into pieces and generate demand scenarios for the model. So that's number one. And also you are right, the production and the supply is random. What we have considered so far, as you saw, was to consider that as an input, deterministic input to the model. But you might think of that as a decision variable that would give insight or guidelines to manufacturers on how much ventilators they should produce in order to satisfy demand. And also, of course, you will have the possibility to consider scenarios for the randomness on the production if you are not willing to consider that as a decision variable. But we believe what we have developed so far is just a first step in order to deal with this situation. We believe there are many possibilities in order to model the problem, in order to capture all the practical considerations that one might come up with. And also, there are many possibilities in order to, I see some questions about the solution quality and also scalability of the approach. There are many ways to improve the model. What we have done so far is just the first step. It was done in, I would say, in a 2 weeks time window. But as I said, we are currently working on improving many other aspects of the problem and put that into operation. I don't know whether I answered all your questions, but I tried to cover as much as I could remember, and my knowledge would allow me.
We'll probably take one more question. I'm going to unmute Andrea, showing no personal bias whatsoever here. Andrea, go ahead.
No personal bias. Hamed, great talk. Nice to see you again.
Very nice to see you.
So you pointed out at the end the fact that in your wrapping up, the fact that essentially the various states can pay strategically in a certain sense, right? I mean, there is some sort of game theory related topic, which is the fact of accepting sharing the resources around. So I guess this is probably a bit hard to incorporate directly in your model, but so this will require some sort of taking responsibility from the federal government to essentially finding a policy which is good enough for everybody and then running your model, right?
Correct. So there are a lot of politics that should be taken into account. One of the political consideration and also practical consideration is that states might not be willing to share the resources with other states. The FEMA, the federal government, has control over part of the inventory, but it doesn't have control over the inventory that the states have for themselves. States, I believe, will be willing to share the resources if there are some sort of guarantees for them. If they share the resources, they will be able to get back that resource if they need it in the future. So yes, so that's why we need a coordinated system, a centralized system that would have the power to control what would happen in practice. Because in reality, there are a lot of things that might be worthy of consideration, as you pointed out correctly. Correct.
Thank you.
Sure.
Well,
so
thank you very much.
We will take the other questions later.
Yes. So let's all thank Hamed one more time through our virtual clapping ability. And I will let Elias introduce our next speaker.
Okay. Thanks, Alex. And thanks everybody for joining. We have 100 people online, so that's quite